So now I would like to introduce Dr. Fiona D'Souza. She is heading the scientific operations at Anderson Diagnostic Services. She is a PhD from Manipal University of Higher Education. She did her PhD in clinical embryology and genetics. She has also done a certified program in genetic testing and sequencing technologies from Harvard Medical School, and she has over 15 years of experience in research and academics. Madam is heading the clinical genetics operations of India, Sri Lanka, and Nepal. She's also heading the genetic counseling division of Anderson Diagnostics, and she has developed personalized diagnostic plans for patients with disorders and runs academic and social campaigns on genetic disorders. Her area of specialization is reproductive genomics, reimplantation genetic testing, non-invasive embryo quality assessment, endometrial receptivity, and rejuvenation. She also has a keen interest in PGD and preventive genetics. Dr. Fiona has more than 13 publications in very high impact journals and very commonly invited faculty at various national and international conferences. She is heading the special interest group of applied genetics as part of Indian Fertility Society, that is IFS. She's an expert member at SRM, Institute of Science and Technology, Chennai, and she also visits University of Colombo and Ruhuna in Sri Lanka. So we are very fortunate to have Dr. Fiona with us. Such a lovely profile she has here. It's all her hard work which is showing up now. And over to you, Dr. Fiona. I'm stopping the screen share and kindly start the session.
Okay. Thank you so much, Dr. Sarappreet, for that introduction. Am I clearly audible?
Yeah, so Dr. Peter has said that voice is not clear. Dr. Peter, we can hear each other clearly. Can you hear us now? I think some network issue at his end. And once the voice is clear, the picture is clear. I think we can start. I think we can start now. Any questions you have, you can post it in the chat box. We'll be more than happy to answer. Or you can answer the question live when the session ends. Dr. Fiona will be happy to answer. Dr. Peter is sorted now. He says yes, he can hear clearly. So over to you, Dr. Fiona. Kindly start. Thank you.
Hello, good evening, everyone. So today we're going to discuss 5 cases of IVF failure, how genetic insights are helping us understand what has actually happened in these 5 cases. So first and foremost, let's define IVF failure. Now, when we talk about IVF failure in general, it can happen at any of the 8 stages of IVF. Now, the goal of every IVF cycle is to deliver a healthy baby to the intending couple. So when we talk about IVF failure, it could mean that there could be a failure to ovarian response. There could be a failure in retrieving mature oocytes. There could be a failure in retrieving good quality sperm. There could be fertilization failure. There could be failure of embryos to develop to blastocyst stage. So you can face arrest at stage or at compaction stage. You can face implantation failure. You can face miscarriages or also fetal anomalies. And each of these stages have different causes involved in them. So when you approach a topic like IVF failure, you need to clearly define what kind of IVF failure it is. The second most important factor to remember is genetics is recurrent. If a particular phenomena is recurrently approaching you, or every single cycle is manifesting in the same way, then the cause is most probably genetic in nature. Now, for example, if you have the first IVF cycle with a poor oocyte quality and a second IVF failure with fertilization failure or embryonic development issues, then the categories can change slightly. So for every IVF failure, you need to document what stimulation protocol was used, what was the yield of GV, M1, M2 oocytes, what were the quality of the oocyte. So always document. Whenever you feel that a ovarian response has resulted in poor quality oocytes, ask the embryologist to take images and document them, because it really helps us to, when we go back and review the case after the second or the third cycle, it really helps us to understand where exactly the challenge is happening. Next most important fact is if it is empty follicle syndrome, or if you have poor quality sperm, or if there is DNA fragmentation. All these have to be documented from cycle to cycle, and these insights help us use genetic tests efficiently. So genetic tests are not a direct approach, as in we sequence the test, we find a variant and we report it. So when we usually do genetic sequencing, we find millions of variants. These variants are reported based on the significance and correlation to the presenting case. So without the case history, we cannot perform genetic testing efficiently. We will give you a result, but we might go reporting certain variants which have been imported. So when you ask for a genetic test in view of IVF failure, you need to clearly define the IVF failure and give a lot of details on how each cycle has failed and what are the challenges that the patient has faced. Based on that, a geneticist can help you get the answers or find solutions to this stepwise. So my first case today is focused on empty follicle syndrome. This is a scenario where follicles are visualized during the stimulation protocol, but on the day of oocyte retrieval, you don't find any oocytes. Now, there are two types of empty follicle syndrome. So there are two types of empty follicle syndrome. First is the false empty follicle syndrome. Now, this mainly happens due to inadequate or a mismatched HCG trigger, and that is why you need to order genetic tests only when the phenomena is recurrent. So in case you have a first IVF cycle resulting in empty follicle syndrome, you need to make sure that first you check the HCG trigger and make sure that it is recurrent. Then only go for genetic testing. So usually the true empty follicle syndrome is present in about 0.045 to 7% of IVF cycles. So if you're a laboratory where you're constantly seeing empty follicle syndrome in a week's time or maybe 3-4 times in a month, you need to look at how your drugs are being stored, how they're transported, their expiry date, how they've been handled, and how they've been administered. Only then we need to head for genetic testing. So this was a case of a woman aged 33 years, presented with long-standing primary infertility, type 2 diabetes in control. She has a history of reproductive treatment failure. She went to 7 IUI cycles. Her husband was normospermic. 2 prior ART cycles characterized by apparent follicular recruitment, 13 to 15 follicles were visualized, but failure to retrieve oocytes. Baseline hormonal evaluation demonstrated a good ovarian reserve, AFC was normal, karyotyping was normal for both the couple. And that is when they came to us and we decided to evaluate this at the genetic level. Key factors for us to choose a genetic test or indicate a genetic test was that there were minimum 2 ART cycles presenting similarly, and the background workup for the HCG administration, everything was already checked. So the main factor before we go for genetic testing was the confirmation. Serum beta HCG on the day of retrieval is the most significant important test for diagnosing genuine empty follicle syndrome. So a low or undetectable beta HCG immediately suggests a false EFS. And you need to guide the management accordingly. But in case the serum beta HCG level is as expected, then you have to evaluate genetically. So we have done the trigger verification, ovarian reserve verification, laboratory trigger timing, injection site, drug storage conditions, aspiration technique was all evaluated. This was within the normal and expected ranges, and then we went for genetic testing. Now, when we chose the genetic testing, now most people think that the most common cause for empty follicle syndrome is a mutation on the gene LHCGR. But there are several other genes involved with empty follicle syndrome. Therefore, ideally, a panel-based testing for empty follicle syndrome is recommended. Now, this particular case, we found the female partner to be having a ZP3 mutation on exon 2. This was a heterozygous mutation. The disease is called oocyte zygote embryo maturation arrest. There are many types. It's also abbreviated as OZEMA. There are many different types of OZEMA. This was basically OZEMA 3. And this was a likely pathogenic variant inherited in dominant pattern. Now, when you mean dominant, we mean that one copy of the ZP3 gene is normal and the other copy of ZP3 gene has a mutation. Now, this mutation could either be inherited maybe from the father, definitely not from the mother, because she has a sibling who is also conceived. So in her case, mainly it could either be de novo, happened to her for the very first time, or could be inherited from the father, because if ZP3 was present in the father, it would not affect him because he's a male. Now, since this is an autosomal dominant mutation, we know that there is a significant impact on follicular genesis, and therefore, even if we repeat a stimulation, the same empty follicle syndrome is going to recur. Based on this report, we were able to clearly counsel her to go for a donor oocyte program, and then she was able to conceive. And this way we had a clear diagnostic path and a clear reason to suggest for donor oocyte program. Now, apart from empty follicle syndrome, you also have other causes of diminished ovarian response. So the first thing is you have poor ovarian response also, which could be caused by certain polymorphisms. Now, when we look at genetic conditions, you have two main categories. You have mutations like the one we found here in this patient. So this is a mutation. It manifests itself fully when it is in a dominant condition. And if you go on to the website called OMIN and you type in this number, you will exactly get the phenotype. So this case, this variant has been reported in other families who are not able to conceive. So based on the literature and clear-cut evidence, we can go ahead for a donor oocyte counseling. But in case there is a diminished response to the stimulation, as in you get fewer oocytes or fewer mature oocytes, then you can also go in for a panel that looks at polymorphisms. Now, the polymorphism involved in ovarian response mainly are LHCGR, FSH, AMH, AMHR2, and ESR genes. And these will modulate the response of the ovarian cortex to the stimulation drugs. Based on these findings, we can titrate the stimulation and then help get a better ovarian stimulation yield. So these are actionable variants, basically, which tells us that we can just change the stimulation protocol and we will get results. But when you have a mutation like this, no matter what ovarian stimulation protocol you change, we have this impact is going to be constant. This is a solid reason for us to go for a donor oocyte program. The polymorphisms is a reason for us to modulate treatment therapy. So this is an example of another case we did where there was poor ovarian response, and this patient had both an AMH polymorphism and a LHCGR polymorphism, which basically means that there is reduced receptor activity, and therefore they were asked to use recombinant FSH or LH and use slightly higher stimulation doses. What are the key insights we learned from this case? Mainly make sure that the empty follicle syndrome is genuine. Once you have a confirmation, then go in for the genetic testing. Genetic conditions usually are recurrent in nature, so prefer a panel-based testing as opposed to a single gene testing here. Informative genetic result can really help us in patient counseling and help the patient make informed decisions. And what points to remember is, don't always assume we are going to find a mutation. So the diagnostic yield of these panels is around 20 to 30%. And there could always be another 70% of cases where you don't find any genetic mutations or polymorphism. In that case, we are left to only repeat the cycle. And then you know for sure this is not a genetic case. My second case today is fertilization failure. Now, how do we diagnose fertilization failure? Mainly if you are unable to see 2P and 2PP at 16 to 18 hours post-fertilization. So here is a female partner aged 28 years and the male partner is 32 years. They were faced with primary infertility consanguis, 4 unsuccessful IUI cycles. He's having asthenospermia, so obviously it did not work. When they went in for ART cycle 15, M1 oocytes were retrieved, where M2 did not go through fertilization. We went in for genetic counseling and requested for whole exome sequencing of the couple. What we found was the male partner was having a mutation on a gene called NLRP7, and the female partner was homozygous for NLRP7. Now, this gene is significantly involved in oocyte maturation, and in case the fertilization goes through, there is a high risk for hydatiform mole. When her second IVF cycle, though we retrieved 10 M2 oocytes, they tried artificial oocyte activation also. There was poor embryonic development, and the couple refused to undergo donor oocyte program here. So we were only left with an adoption option for this couple because this mutation is significant. Because she is homozygous, all her oocytes are going to be defective, and there is no way she can conceive in self gametes. Since this is a oocyte maturation defect, it is not an endometrial defect. So, a donor embryo or a donor oocyte program will work just fine for this couple, but they refused to do that because of on religious grounds, and therefore we could not proceed further with this case. So how do we categorize fertilization failure? If less than 25% oocytes are fertilized or 0% oocytes are fertilized with ICSI, it is categorized as fertilization failure. The normal fertilization thresholds that we anticipate in ICSI is 70% and conventional IVF is about 60%. Now, what we need to do is document clearly how many M2 oocytes were retrieved, and only M2 oocytes should be calculated for fertilization rate, and how many 2PN embryos were seen at 16 to 18 hours. You can classify fertilization as complete fertilization failure, like 0 oocytes fertilized, severe fertilization failure, almost about 25% or more, and poor is more than 50% were failed. You need to review lab records, ICSI timing, oocyte handling, especially the medium in which the oocytes are retrieved and matured, because oocytes are extremely sensitive to pH changes. And if a pH change occurs, your oocyte is already losing its viability, so your fertilization may not anyway work. And in these cases, genetics is not the answer. So you need to look at the media lot, the incubator, the ICSI process, and if everything is normal, then you look at genetics. Now, the interesting part about fertilization failure is you have both male and female factors involved. And that is why for fertilization failure, you need to evaluate both the male and the female partner. If you have empty follicle syndrome, poor ovarian response, we evaluate only the female partner. But once after the fertilization stage, we face any issues, both the partners are evaluated. There are a number of genes involved with fertilization, as the most important being PLC zeta 1, because this is a sperm related variant and it is what opens the calcium stores inside the oocyte, which basically triggers oocyte activation. And mutations on PLC zeta 1 have been shown to have fertilization failure. You also have multiple oocyte-related genes called WE2, TAB8, etc., which can also trigger oocyte-related fertilization failure. What are the mechanistic categories? A, if it is conventional IVF-related fertilization failure, you have zona binding defects. Here you have to look at acrosome reaction, PLC zeta deficiency. You should also look at Caspar gene variants, which basically don't allow the sperm to achieve hyperactivated motility. So conventional IVF can fail in those categories. When it comes to female factors, we have to look at oocyte maturity. The mitochondrial content in the oocyte cannot be evaluated because there are some technical challenges. We cannot really use the oocytes later for fertilization. Zona pellucida abnormalities, oocyte activation failure, and also advanced maternal age can impact oocyte quality. If you have too much of granulation, also you have poor outcomes with fertilization. Lab-related factors like culture media, ICSI technique, the incubators especially, is the incubator appropriately humidified? Are your CO2, O2 levels normal? All these factors need to be taken. So when it comes to male or female causes, there are several studies which have documented differential response to rescue ICSI or if we do assisted oocyte activation. Now, the point being, if you have a sperm-related factor diagnosed in the couple, and then you go in for fertilization with ICSI with artificial oocyte activation, the odds are, if it is the first three variants, if it's PLC zeta 1, ACTL7A, you have a good probability of achieving fertilization and good outcomes. However, if it's an oocyte-related factor, fertilization with ICSI plus artificial oocyte activation has failed to give any informative results. So we need to make sure that when we are offering situations like rescue ICSI or artificial oocyte activation, we need to make sure that it is a male factor and not a female factor. And genetic testing is a good way to establish that. So how do we plan the rescue interventions and escalations? First, if it is total fertilization failure, no PN at 16 to 18 hours, the outcome has been shown to be modest if you try a ICSI. This is after conventional IVF failure. If you do artificial oocyte activation immediately post ICSI, the fertilization rescue rate is 60 to 80%. If it is a case of high DFI, now DFI usually does not affect fertilization rate, but in case there is high DFI, you can plan for testicular sperm. It lowers the DFI by 50%. This can improve embryo cleavage rate and developmental rate. In case it is poor maturity in the oocyte, the next cycle trigger can be changed to maybe a GnRH unlock or high dose beta HCG. Now, extended culture may not always help. Only if it is 2PN, it is viable. Otherwise, no. Donor sperm and donor oocytes remain always the option. But what we need to remember is when you offer rescue ICSI post 20 hours after insemination, the outcomes have always been poor. So it is better to try at least, but always go for the next cycle after severe proper evaluations. Key insights for this case, mainly evaluate lab conditions first, oocyte quality second, then go for, once it's established that there is no other confounding factor, go for genetic testing, test the couple. Test you can use for the couple could be infertility panels that each company might have, or go for whole exome sequencing. This will basically look at any mutations are associated with defective oogenesis or spermatogenesis. Points to remember, there is always a possibility genetic test is not going to be informative, because this has happened to me in many cases where we were not able to find the results. And obviously, when we make presentations and we're discussing cases, we will find a case which has given us a yield, but there will always be cases where there is no informative outcome out of the genetic test. So if the genetic test is negative, you can always plan another stimulation cycle. The odds of the condition recurring will be low. My third case today is embryonic arrest. Why do embryos fail to cleave and fail to reach blastocyst stage? Now, this is a case of a male partner, 29 years old, DFI is at 17%. Female partner is 28 years old, good AMH, has 3 cycles of self-gamete IUI failed. In 2024, she went through an ART cycle, 14 oocytes were retrieved, only one was M2, 2 were M1. It was left for maturation, and once it became M2, 3 oocytes were frozen. In the next cycle, 14 oocytes were retrieved. Here, the stimulation dose was adjusted, so they found 14 M2 oocytes, and they used the previous 3 M2 matured, 2 IVM oocytes and 1 M2 oocyte also. And here they were able to achieve 13 oocytes that were fertilized. Out of the 13 fertilized oocytes, only 1 developed to blastocyst at day 6. And when it was transferred untested, it resulted in an anembryonic pregnancy. Now, again in 2025, went through another cycle, 18 oocytes, 13 M2 oocytes, 12 fertilized, again no blastocyst found. So we went in, we definitely looked at it from a female infertility point of view, because it looks like a significant maturation defect. And when we did the test, so we do have a female infertility panel of about 600 variants included into it. So we found a mutation on TUB8, and this is a significant gene involved in oogenesis and embryonic development. It also falls under the OZEMA category. So this is oocyte zygote embryonic maturation arrest type 2. And this variant was in the uncertain significance category. Now, this is homozygous, which means that both genes are carrying this variant. Now, because it is uncertain significance, now if you look at genetic testing, we have 3 main categories. We have pathogenic, likely pathogenic, and then you have the VUS variants. Variants of unknown significance are basically new mutations which are not documented in the database of genetic variants. So they're not very actionable directly according to ACMG guidelines and most guidelines that govern genetic testing. However, there is a significant phenotype to genotype correlation, and this is how we approach such cases. We look at the variant, see if any other family member is having similar presentation. In her case, there was no other family member who had a similar presentation. And across 3 IVF cycles, she's constantly facing the same challenge, which leads us to believe that there is a high probability that this is the variant that is triggering the problem. And it has been reported earlier. The gene has definitely been reported, but the particular mutation is not been reported earlier. So this was another case which was reported with TUB8 mutation, which showed similar findings: poor cleavage rate, poor fertilization rate, poor maturation defects. So this way, we were able to convince her, saying that this is a case where you need to look at oocyte donation options, and then she was able to consider the donor program. What we need to understand with genetic factors affecting oocyte and embryonic quality, there are multiple genes that are involved in multiple stages of oocyte and embryo development, starting from maturation to fertilization, cleavage rate, and embryonic development. So definitely go for a panel-based testing, because TUB8 is not the only gene. And if you have an embryonic arrest, don't say, I have a patient whose embryos have arrested, I'd like to do TUB8 testing. Always preferably go for a panel-based testing, because this is more informative and saves a lot of time. Because what we have experienced is IVF patients are already frustrated and really impatient. So the panel-based testing helps us achieve diagnostic yield faster as opposed to just single gene testing. Now, key insights are embryo. What you need to always remember is embryo developmental delay and arrest is not always genetics. It also depends upon the quality of the oocyte, the quality of the sperm, the internal genetics, chromosomal content of the embryo as well, apart from genetic predisposition. So investigate other causes, rule out laboratory factors, stimulation protocol, and a very important factor is sperm DNA fragmentation index. Now, Eshe says that DFI, sperm DFI is not routinely recommended. It can be used for explanatory processes, but DNA fragmentation in sperm is a strong factor which actively reduces cleavage rate, actively results in compaction arrest and reduced blastocyst formation and implantation failure. And if we have a high DNA fragmentation index, some therapeutic interventions and lifestyle changes can really improve the outcomes. And if we forego these and expect only the lab to get a better yield using MAX or any other special sperm preparation techniques, we are still reducing the chances of the laboratory people to find you a better sperm for fertilization. And if all these factors are ruled out, look at genetic testing. It can aid in patient counseling and help patients decide donor-oocyte program. Now, what if this patient had already decided to go for a donor-oocyte program before she reached the third IVF cycle? Genetic testing then can be let go. So it depends on the patient choice. Some of our patients are very particular to not use donor-oocyte program. That time, these tests are really informative. And for patients who are ready for donor-oocyte program, we can skip it. So if you look at the Indian scenario, we also have a challenge in having access to enough oocyte donors because now we have different rules in place. So in such cases, these are truly indicated cases where we can proceed with ODs. My fourth case today is slightly complicated. It is a case of implantation failure. Now, we know that 10 to 25% of IVF patients undergo implantation failure, and this is truly a multifactorial cause, and it is difficult to pinpoint a single cause for implantation failure. So this requires extensive stepwise evaluation and might take more than 1 or 2 cycles to troubleshoot. So, oh, sorry, I missed the age of this lady. So she was a 34-year-old woman. The husband was 39. Semen parameters were normal, regular menstrual history, no significant clinical history apart from this. DFI was not done when they came to us. One cycle in 2023 had 6 embryos formed. First FET2 embryos implantation failure, second FET2 embryos implantation failure. The 2025 cycle also resulted in 12 embryos. Again, 3 embryos were transferred, implantation failure, 2 embryos were transferred, implantation failure. Now, what is important to see is this now falls under a true recurrent implantation failure case because she's undergone 4 ETs, but we have to see are the embryos of good quality, and second, they were not tested. So now when she goes on for her next cycle, the first test that we will include into her IVF cycle is PGT-A. Now, according to ESHRE, we have now a refined diagnosis for recurrent implantation failure. So now it is a age-wise criteria, and you can also subdivide it into were the embryos tested or not. So in the age group from 35 to 40, if the embryos are of unknown aneuploidy, you can intervene in age 35 after 3 ETs. Age 35 to 39 after 4, because the probability of aneuploidy is higher in this category. And they say intervene after 6 for beyond 40, and 6 is little too much for us to wait for. So, but when you include the transfer of euploid embryos, the criteria becomes way more uniform. So in cases of euploid transfers, irrespective of age, recurrent implantation failure is diagnosed after failure of 2 euploid transfers, preferably single embryo transfers. Now, if we have to troubleshoot the pathophysiology of implantation, you need a competent blastocyst, good quality, good morphology, chromosomally normal, a receptive endometrium, an endometrium free of pathology, intact nuclear support, and you also have autoimmune factors, which are a rising criteria people evaluate now. To look at embryonic factors, aneuploidy is the strongest, most leading cause of implantation failure and reproductive failure in human beings. A suboptimist blastocyst quality should also be considered, and then you have mosaic embryos also to consider. But the first intervention is always PGTA. 50 to 60% of causes of implantation failure are attributed to aneuploidy. And that is why HTA also factors this in. And the impact of mosaicism on implantation is also well established. So if you have a mosaic embryo, as in when the number of chromosomes involved in the mosaicism and the size of chromosomes involved in the mosaicism changes, your live birth outcome will progressively drop. For example, if it's a segmental aneuploidy, it's a small chromosomal change. Its impact is lower than a whole chromosome aneuploidy. Then if you have one chromosome with whole chromosome aneuploidy versus two chromosomes versus three chromosomes, then the outcome progressively declines. What is important to understand is you still have ongoing live births reported with mosaic embryos. So I think the next session with Dr. Rajni will help you understand how mosaicism works and how that interpretation goes as well. Now, PGT is a tried and tested method to solve the challenge with implantation failure. This is just one of the studies I've quoted, but there are multitude of studies with huge number of patients involved. And you see that the clinical pregnancy rates are always higher with PGTA. The miscarriage rates are lower with PGTA. Your ongoing pregnancy rate and live birth rate is always better with PGTA. Now, the challenge comes when euploid embryos fail. And if you see the chart, you already can see that your clinical pregnancy rate here at 61%. That means the remaining 40% embryos have failed to implant. You already have an ongoing pregnancy rate of 47%. So in the euploid category, also have about 13% of embryos failing to continue a pregnancy to live birth. So these are important facts you need to factor in while looking at PGTA. PGTA is not a foolproof solution that guarantees you a live birth, but it definitely reduces risks and improves the chances of achieving successful implantation. So why do euploid embryos fail? There was a beautiful review published in 2023 on the black box of implantation failure. And this review looked at multiple studies which evaluate embryonic factors, male factors from DNA fragmentation, maternal factors like the receptivity, uterine anomalies, the synchronization, microbiome, and several factors. So this is the main reason that we do not guarantee a pregnancy with PGTA. It improves your chances of an implantation and reduces miscarriage risk, but it's not a foolproof test. So how do we troubleshoot recurrent implantation failure? First, look at embryo factors, the quality, blastulation rate, aneuploidy, PGTA can be included. You can look at receptivity, which helps you understand the window of implantation. You have to rule out chronic endometritis, endometriosis, any kind of structural defects like polyps, fibroids, adhesions, and look at the hormonal menu if you're facing progesterone resistance or not. And then you also have the immune and systematic evaluations, which are now upcoming evidence. My fifth case is, okay, I have implemented PGTA for my patient with, say, recurrent miscarriages or recurrent implantation failure or advanced maternal age. These are the three main indications for PGTA. What do I do if all the embryos are aneuploid? So mainly the primary cause of IVF failure is aneuploidy, as I said, and PGTA often results in cycle cancellation because all the embryos are abnormal. Now, until now, we know that most of the aneuploidies are maternal. This is our understanding. These aneuploidies now are getting subcategorized. Apart from being maternal or paternal, we have to look at meiotic origin if they're coming from the oocyte or the sperm, or mitotic origin. The standard PGTA will only tell you, yes, this embryo is aneuploid and here is the aneuploidy. It does not tell us where is the aneuploidy coming from, which has resulted in lot of ambiguity while deciding PGTA results. So there have been a lot of papers also that have published which show that your PGTA aneuploid embryos have resulted in healthy live births. Recently, there was a few months ago, there was a fertility sterility article which showed the live birth of two embryos which were aneuploid, which were transferred. Now, because of this, the current PGTA, which is the NGS-based PGTA, is also limited. However, we have better solutions on the horizon. The newer version of PGTA now incorporates both copy number variation, which is your standard PGT, SNP analysis. Now, the SIP analysis basically gives a molecular fingerprint of the parents and the embryo. And based on these signatures, you can actually evaluate where is the aneuploidy coming from. So the origin of aneuploidy analysis is the next version of PGTA which is coming into practice. It's already available all over the world. It has been around for a while now, and basically this level of testing includes both parental analysis along with the embryos. We need to sequence the male partner and the female partner's samples along with the embryo, and we generate what we call a genotype. So here you can see you have a male genotype and a female genotype. And if it is normal, you have one copy of each. Now, if I have, say, a monosomy, that means one chromosome is missing, and I have this signature and I know it's from the male partner, that means the missing chromosome is coming from the female partner, so I know the monosome is maternal. Same way goes for trisomies. What the FNP-based testing does is gives us good clarity, higher resolution, and reduces mosaic calls, helps us troubleshoot why all embryos are aneuploid. So this was a case of female partner, 36 years. So she's under advanced maternal age category. Her husband is 37 years, actinotetrazoospermia, DFI is 22%, mildly dyslipidemic, has occupational exposure to radiation for past 4 years is what he tells us. And they went in for a first cycle in 2025. They retrieved good number of oocytes. 8 day 5 embryos were formed. The oocyte quality was slightly poor. They decided to test only 4 embryos, remaining embryos were frozen, and 4 embryos turned out all 4 embryos were aneuploid. Now, since she's advanced maternal age, her aneuploidy risk at this age group is around 40 to 45%. So they decided to test the remaining 2 embryos. Both of them again came aneuploid. The first testing was done with another lab, the second testing was done with our lab. So when they came to us for post-test genetic counseling, we said, okay, look, we have a new solution now, which will tell us where this aneuploidy is coming from. And instead of assumption, let's look at it. The main indication was, his DFI was slightly on the higher side, and he's having occupational radiation exposure, and then she is advanced maternal age. So they were wanting to understand, okay, we are ready to change one gamete, but which gamete do we change? Can you assure us that this won't recur again? So both were doctors, so they were very open to alternate technologies. And when we did the PGT with the new version of the test, we now found that both the aneuploidies were paternal in nature for the 2 embryos that we tested. So the first embryo had a segmental gain on chromosome 1 and a segmental gain on chromosome 2. Both of them were paternal in origin. And the second embryo also had a meiotic paternal gain on chromosome 1, again chromosome 3 trisomy, chromosome 5 trisomy, chromosome 9 trisomy, and a segmental gain on chromosome 14 and a segmental loss on chromosome 20. Now this was balanced. That means it is neither maternal or paternal in nature. But here we know there's a significant paternal contribution to the aneuploidy that we observed. So we were able to help them understand where this is coming from. They can make an informed decision accordingly. And just to summarize, when we look at multiple genetic presentations, we know that about 13 to 20% of IVF failures are genetic in nature, but it is very important that genomic testing is the last step of all these factors. A clear troubleshooting has to be done before we choose genetic testing, and give as much information possible to the genetics lab. Now, as a part of a genetics lab, I can tell you that about 60% of the cases that we get for genomic sequencing in cases of IVF failure don't have a clear clinical indication explaining to us what is the case, where is the failure happening. In many cases, we choose not to report variants because of lack of this history. And only when we go back to the patient and the clinician and we get all the information, again, the report gets revised and we have informative results. So when it comes to genetic testing, deliver clinical history in as much detail as possible, or else connect the patient to the genetic counselors from the laboratory. They will extract all the information themselves, and that will help us use the genetic testing more efficiently. We need to remember that we cannot repeat cycles blindly. Sequencing the genome can be informative if done properly. When it comes to sequencing and the analysis, it is important to assess phenotype to genotype correlation. And this is important for no matter what genetic test you do. And based on these results, we can truly have a personalized protocol ready for patients to help them have a better IVF outcome in the next cycle. Thank you so much. Just to remind you that our course is starting on the 3rd of June, and you can contact these numbers to register for the course. Thank you. We can take
Dr.
some
Fiona,
questions.
yeah, wonderful, wonderful, presentation. So many points were cleared, and I agree that this is a very upcoming field, and new things are coming up. So it was a very insightful, presentation. I have two things which I have understood, and I want you to please correct me if I am wrong. Number one is that most of the things we are doing genetic, there is actually helping us in patient counseling, and maybe to some extent deciding on whether we go for a donor egg or donor sperm or something like that, because if you have to go for donor sperm, things are very easy. You just need to do a IUI. Second thing, that DNA
Yes.
fragmentation index, mostly most of us are now in cases of failure using zymo chip. So this is like sort of a remedy being given instead of going for investigation, because sometimes the investigations are very costly. So my question to you is that when we are doing PGTA, so I had this impression that if the females are younger, or the couple are younger, so probably this is not going to help us much. This was one thing. And second thing is that if we are going for repeated failure cycles, do we need to do anything other than PGTA? I mean, whole exome sequencing and carrier matching, because that question always comes to my mind, that what do I do first? Do I evaluate them first by doing a karyotype? Is definitely we are doing, but other than that, whole exome sequencing or carrier matching, should I do that first, or do I do another cycle and do PGTA first?
So, in cases of implantation failure,
Mm-hmm.
whole exome sequencing is not
Yes,
informative,
yes,
ma'am.
yes.
So, for recurrent
Pardon,
pregnancy
I
loss
didn't get
and
you.
implantation
Sorry,
failure,
I
whole
didn't
exome
get you. Your
sequencing is
voice is
not.
breaking.
Can
I
you hear
didn't
me
get
now?
you.
Am I audible?
Sorry.
Dr. Fiona, it is much better now.
I'm sorry, I didn't get you.
Yeah. Can you come again, Dr.
Are
Fiona?
you able to hear?
Now we
Yeah,
can
I can
hear
hear you,
you.
sir.
Your voice is cracking too much. I didn't get you at all.
You can
I'm
say it
able
again,
to.
Dr. You you can repeat your answer, Dr.
Can you
Fiona.
hear me now?
Yeah, it's much better. Yeah.
Okay, so recurrent implantation failure, the testing modality is far more complicated. We need to look at PGTA, but you also need to have a long list of endometrial evaluations also done. We need to look at progesterone resistance, the possibility of chronic endometritis, endometrial receptivity, microbiome balance, as immunogenetic regulation between the endometrium and the embryo. And because it's a five-step process, all the factors need to be considered for
Yeah.
implantation failure. Troubleshoot
Yeah. Yeah,
implant is
that I understand. But that I understand. Let's assume that we have checked all other factors. Now, before doing another cycle, should I do this whole exome sequencing, or should I proceed directly for PGTA?
no. If it is implantation failure, whole exome sequencing is not informative.
Okay, not informative. That is what I wanted to know. Okay, okay.
If you're getting
And
good quality and
okay.
PGTA is done, whole exome sequencing is not informative. For embryonic arrest, for oocyte developmental problems, whole exome sequencing is informative.
Okay. And you
Not
talked
for
about PGTA, but what about this? Like, is there any role of HLA and key typing, immune factors, where we talk about HLA matching, key typing, and all those things which are still a little more complicated to understand. So we should be checking that also before we go for another cycle, right?
well, ma'am, the challenge is now genetic testing is evolving science. We don't have
Yes,
solid
yes.
literature about. That is the
Fantastic.
reason it's not in the recommendations yet. But we do also have another course on immunogenetics. There is a bundled offer as well, which explains all the immunogenetic testing and evaluation. We have different faculty to take care of that.
Okay, okay.
So, on the
Just to
testing
Okay.
inform
modality,
the yeah,
available.
Okay.
the
Okay.
We can
Thank
do
you.
investigation.
that.
Thank you. Thank you.
Yeah,
Thank you.
welcome, Dr. Nish.
What
So
should be
remote,
done for
it just doesn't work actually. Yeah.
sorry, sir?
Can you hear me? No, you can't.
Yeah, I can hear you.
So the point I was trying to make is that in cases of very high DFI failures, like exceeding 40%, especially on flow cytometric testing and all, and none of the modality will help. You have to maybe go for a testicular sperm only. So Zymot might help if the DNA damage is, moderate, mild to moderate, but not in cases of severe damage. I've never seen that working.
Okay. Okay. Thank you. Thank you. Thank you, doctor.
Yeah.
Okay, so Mr. Rajkumar Lohar has a question. The pedigree is autosomal recessive. I think you're referring to the NLRP7 case, if I'm
Second,
not mistaken.
second question, I think he's referring to.
Yeah. So mainly, what I understand is, if you're asking about the NLRP7 case, the male partner was a carrier for the same variant, but the female partner was homozygous for the same variant. So it is an autosomal recessive condition, but she is homozygous, so she's affected case. Even though it is a recessive condition, because both her genes are affected, it is manifesting and her oocytes could not develop. And mainly aged advanced, I don't understand if this HLA-G pattern screening. HLA-G is actually a transcriptomic factor. It's an mRNA expression. The concentration of HLA-G is very low and usually has to be evaluated in the trophectoderm cells. And there are no testing modalities right now. Maybe it's done in a research context, but in human embryos, it's going to be extremely challenging. So right now, HLA-G is not tested in embryos.
So,
What test will be done for
yeah,
before PGT? Yes,
so
sir, you were asking something.
yeah, no, I was just reading the question. So I think it's Anand Lakshmi. She's one of our faculties only. So Anand Lakshmi is asking that
Okay.
which test will be done for parents before PGT-AO along with embryo biopsy?
A test. You don't need a test before PGT-A. Before PGT-AO is basically PGT for origin of aneuploidy testing. The parental DNA samples are tested simultaneously with the embryos. So it's not like PGT-M where you need a pre-PGT workup. You run the samples for global SNP screening. So with PGTM, what happens is it's a local mutation and there are SNP markers around it. But for PGT-AO, you need to have genome-wide coverage because aneuploidy can occur in any chromosomes and we don't know that in advance. So the test is developed such that it looks at global SNPs all over all the chromosomes. So based on that, the algorithm itself will match the SNP signatures between the aneuploidy and the parents and tell us from where it's coming. Any other question?
So any other question you can ask, you can unmute and ask.
So this is done by Anderson Lab.
Yes, it is done at Anderson.
Okay. And any idea about the pricing for this? The panel you suggested for male and female.
Pricing is with my sales team, so you will have to write to them
Okay.
or contact them.
Maybe Dr.
You can
Saram can put us in touch.
Yeah, ma'am,
Okay.
I'll call you and tell you.
Please, please do that. Thank you so much.
Definitely,
Thank you. Because we do have many cases nowadays, more and more with recurrent failures.
Yeah.
Yes.
Yeah. So, Dr. Fiona, I don't see any other question in the chat box. So,
Ma'am,
yes, Dr. Usha,
Yes.
please ask.
ma'am, it's excellent presentation, madam. So we want to extend the work to the transcriptomic profiling also, if possible, on those coming days, because we can able to analyze what are the stress markers that are leading to the failure of an IVF, and we can rectify it and we can go with that, madam.
So this is still in a research context, so it will take time for transcriptomic profiling to come into actual clinical practice from the embryo side. But the endometrial
Yes, ma'am.
transcriptomic profiling we are already doing for receptivity testing. From the
Yes, ma'am.
embryonic side, it right. So if you don't have any other questions, I think close the session, and the details of the course are available in the WhatsApp group.
Yeah, we can close the session. The course commences on 3rd of June. There'll be another demo class on mosaicism, which I'll be taking, and Dr. Rajni will be moderating. That's on 2nd of June. So early bird is till 28th. That is tomorrow. So if you want to register in the present fees, which is the discounted fee structure, you can register by tomorrow. Otherwise, after tomorrow, there'll be a nominal hike in the fees. So, and the registrations are open till 2nd of June. The course
And
commences on
Dr.
3rd of.
Sarab, what is the price of? Can you just give an idea about that also?
Ma'am, it's 10,000. I'll send you the link, ma'am.
Okay, thank you.
You
Thank
can
you.
review the topics also, ma'am.
Ma'am,
Yes, though.
ma'am, ma'am,
Yeah, Dr. Visha, please.
may I
Please.
ask question, ma'am?
Yeah, please ask. Dr. Fiona is.
Actually, like this is very good lecture. We want to have this lecture in our university also. Is it possible that we can plan for one lecture as an invited speaker? We can invite Madam and Sir in our University of Madras, the Department of Genetics.
Yeah, ma'am. I
You
think
can
it
contact
is
us directly
yeah.
in the group as well.
Yes, sir. Yes, sir. Thank you. Because nowadays students get benefited and they get aware of all those things. Thank you, sir.
Thank you, ma'am. Thank you. It will be an honor for us. Yeah. Right. We end the session then, Dr. Fiona.
Yes, sir. Thank you, everyone,
See you
for
in the
listening
course. Yeah.
to the course.
Bye. Bye.
Bye.
Bye. Good night.